Hello everyone, so welcome back. This is the second section of hemorrhage in early pregnancy, and here we are going to learn about missed miscarriage. So you missed something. So it is also known as early fetal demise and occurs when the fetus is dead but retained inside the uterus for a variable period. So it is dead, meaning over, but retained inside the uterus, it's present inside the uterus for a variable period of time. So the patient may not exhibit typical miscarriage symptoms immediately, and that's why it is missed. And the condition is often detected during routine examinations or ultrasounds. So with this it makes sense what the definition means, what the term means, missed miscarriage. So let's look at the pathology. So the causes of prolonged fetal retention in the uterus. So this is the keyword here. A prolonged fetal retention in the uterus are not well understood. The pathological changes vary depending on the gestational age. So there is before 12 weeks, after 12 weeks. So the let's see beyond 12 weeks what it is. The retained fetus undergoes maceration, which is softening due to autolysis. I think we have learned this in forensic. And or mummification, dehydration and shrinkage. So either one of these two processes, one is maceration, otherwise it is mummification. Let us look at this thing, maceration, what it looks like. So maceration, something like this, yeah. Fetus, maceration fetus. How do I change this? Can you tell I am recording it? Yeah, over here, yeah, maybe something like this, yeah, or mummification. You know how a mummy looks like, yeah, that is mummification. And there is the liquor amni is absorbed and the placenta becomes pale, thin and may adhere to the uterine wall. Pale, thin and may adhere to the uterine wall. So that is after 12 weeks. So one, they are talking about the fetus wherein there is maceration and mummification. Other one, the liquor amni, amniotic fluid, which is gone, placenta becomes pale, thin and it adheres to the uterine wall. And before 12 weeks, so this is what happens, the ovum becomes more or less surrounded by chorionic villi. So that is, yeah, there. The pathological process differs with incomplete separation from uterine wall, but this thing is different. What is it? The pathological process with incomplete separation from the uterine wall. So this is there, incomplete separation from uterine wall. So that is what before and beyond 12 weeks. Here it is very small, here it is slightly big. That's why we are talking about the fetus and placenta. Coming to clinical features, patients with missed miscarriage may present with subtle or absent symptoms, often discovered incidentally during routine prenatal care. Key clinical features include persistent or brownish vaginal discharge. So that is one. We'll look at, we'll read the headings once, then we'll go to the this one, description. Second one, cessation of pregnancy symptoms. Third one, regression of breast changes, cessation of uterine growth, non-audibility of fetal heart sounds, cervical changes, immunological test for pregnancy, real-time ultrasonography. So the first one, persistence of brownish vaginal discharge. So a common sign, typically painless and light. Common sign, typically painless and light. So second one, cessation of pregnancy symptoms. So there is no, this one, what is it, these nausea, breast tenderness and other early pregnancy signs. Next one, retrogression of breast changes. Breast engorgement reduces and breasts may become softer. Cessation of uterine growth. The uterus fails to enlarge according to gestational age. Non-audibility of fetal heart sounds, detected using Doppler ultrasound. So fetal heart sounds, those are not audible anymore. Cervical changes, the cervix feels firm and remains closed. So it is closed, that's why it is missed. It is retained inside. Immunological tests, UPT may remain positive for some time due to persistent beta HCG. Real-time ultrasonography reveals empty gestational sac or absent fetal cardiac activity. So these are the key clinical features. Coming to complications, So, missed miscarriage can lead to several complications, especially if retained for a prolonged period. So, what are those? Coagulation disorders. So, rare but serious, especially DIC if dead fetus is retained for more than 4 weeks. So, if more than 4 weeks, risk of DIC is present. Next, coming to the infection, risk of septic abortion if not managed promptly. Psychological impact, emotional distress, anxiety and grief are common. Future pregnancy risks, increased risk of recurrent miscarriages or preterm labor in subsequent pregnancies. So, that is another one. Next, coming to management. So, there is one this one, expectant medical management and then finally surgical management. Just like you might have heard of MTP, over there too we have medical and surgical management, not this. So, here we have something which is slightly different. So, expectant management. So, uterus less than 12 weeks. Many women spontaneously expel the fetal tissue. The patient is monitored for signs of infection or excessive bleeding, which is over here, signs of excessive bleeding and infection. So, then there is medical management. So, we have some key drugs, prostaglandin E1 and there is also oxytocin. So, first one E1 800 microgram vaginally in posterior fornix, repeated for after 24 hours if needed, repeated after 24 hours. Expulsion usually occurs within 48 hours. So, within 2 days. So, first is in posterior fornix, repeated after 24 hours if needed and expulsion within 2 days. Next one, for uterus greater than 12 weeks, 200 microgram inserted vaginally every 4 hours and a maximum of 4 doses. Here the dose increases in the second one. So, first 800 microgram, here 200 microgram every 4 hours, same route, maximum 5 doses. Next, coming to oxytocin, 10 to 20 units in 500 ml of normal saline, administered at 30 drops per minute. 30 drops per minute, 500 ml of normal saline, 10 to 20 units, 10 to 20 units in 500 ml of normal saline, administered at 30 drops per minute. Escalating doses up to 200 milli international units per minute may be required if initial treatment fails. So, again 10 to 20 units in 500 ml of NS, 10 to 20 units 500 ml NS at 30 drops per minute, escalating dose up to 200 milli international units per minute if this one fails. So, 200 is if the first one fails. Finally, coming to surgical, evacuation of retained products of conception, so that is ERPC, and then there is this reminds me of that surgical gallstone procedure. Yeah, I can't endoscopy. Yeah, dilation and curettage. Dilation and evacuation. So, that is another one. So, here evacuation of retained products of conception. So, required if medical management fails. Ultrasonography confirms an empty uterine sac cavity post treatment. So, that is ERPC. Dilatation and evacuation DND performed when cervix is soft after prostaglandin use. So, after prostaglandin use, mechanical dilators like for example laminaria tents. So, better to look at this are used if the cervix is closed. So, let us see laminaria tents how they look like. So, this is used in this case. Finally, coming to prognosis, the prognosis after missed miscarriage depends on prompt management. Timely intervention reduces the risk of complications such as infection or DIC. So, that is one. Next, coming to future fertility, most women can conceive again with minimal risk if miscarriage is managed appropriately. So, that is about the prognosis. So, with this we come to the end of this topic, missed miscarriage, and which was very interesting. Yeah, so in case you like this particular video, you can like it. In case you would like to contribute something, you can write it in the comments or the Instagram DMs. And yeah, if you have any suggestions related to the website, any correction or anything of that sort, you can also contribute. Bye bye.